Hello, my name is Monica Tennant, and I'm going to be briefly reviewing sepsis, how the pathophysiology links to your physical assessment of your patients. I'm a clinical nurse specialist with over 24 years of experience in both acute and critical care settings, and I have a website with more tutoring, tips, shopping, and other resources available at www.Nomadic-Nurse74@yahoo.com. Every second, a person is hospitalized for sepsis. Sepsis is the systemic inflammatory response to a documented or suspected source of infection. It's the leading cause of death in our hospitalized patients. Approximately 1.7 million adults in America develop sepsis every year. 270,000 of those die of sepsis, and 1 in 3 hospital deaths are due to sepsis. The underlying comorbidities are cirrhosis, immunosuppression, and vascular disease, which have been linked to 30-day mortality rates with sepsis. Some of the common origins of sepsis are typically 35% had a lung infection, such as pneumonia. 25% had a urinary tract infection or a kidney infection. 11% had a type of gut infection, and 11% had a skin infection. So let's go through the pathophysiology of the respiratory infections and how they progress to sepsis, but what you're going to see when you actually do your physical exam. Sepsis causes an increase in vasopressin, and the vasoconstriction, increased heart rate, blood pressure, and increased endothelium are all ischemic hypoxia. And those are activated by the sympathetic nerve-adrenomedullary system. So it increases those catecholamines, angiotensin, vasopressin, and endothelins. Vasopressins, for a start, they constrict your arterioles. And what that does is causes an increase in your peripheral vascular resistance, and that decreases the flow to those pulmonary tissues. What you're going to see when you assess your patient is decreased SpO2s and decreased end-tidal CO2s. Next up, we talk about vasoconstriction. That unfortunately causes a failure of your precapillary sphincters. Blood ends up pooling in those capillary areas or those precapillary sphincters, and those can actually progress into blood clots. And if we're specific to the respiratory area, we're looking at potential pulmonary emboli. You will also see, before you get to the pulmonary emboli, a decrease in capillary refill. So be sure to do that very simple assessment technique with your patients. The increased heart rate and blood pressure is typically what causes some anaerobic metabolism. That leads us into a metabolic acidosis, which we'll see affects a lot of our other body systems. That metabolic acidosis increases the lactic acid, and the lactic acid is one of the hallmark signs of sepsis. So that lactic acid is influencing the respiratory effect. It's actually going to increase the respiratory rate and also increase the effort that your patient is doing to try and breathe and truly try and exchange that oxygen and that carbon dioxide. Endothelium increases in the respiratory infection progressing to sepsis. This causes bronchoconstriction. It increases the blood pressure not only throughout the body, but the blood pressure that's actually through the respiratory system, which causes a pulmonary hypertension. And that's where your patient is significantly short of breath, and they may actually have syncope due to this. So to wrap it together, if you're trying to say, what does vasopressin increase do? It decreases your SpO2 and your end-tidal CO2. What about vasoconstriction? That's where you see your decreased capillary refill, which is typically less than 3 seconds. An increase in endothelium will actually cause shortness of breath and syncope. And the anaerobic metabolism causes the tachypnea that you will witness with your patients. So moving on to urinary tract infections. In their progression to sepsis, there's increased vasopressin, and I want you to think about it as antidiuretic hormone, or ADH, when we're talking about vasopressin with the urinary tract. There's an increase in angiotensin and an increase in catecholamines. So that vasopressin actually increases the water reabsorption back into the circulation by the kidneys. Now that's good, except for the increased sodium absorption can cause electrolyte imbalances. This concentrates the urine and decreases the volume of urine. Now the increased angiotensin leads to vasoconstriction, which increases the blood pressure, stimulates sodium retention by the kidneys, and then angiotensin activates the vasopressin production, which again is your antidiabetic hormone and will lead you to assessing for concentrated urine and decreases in urine volume. Lastly, your increased catecholamines increases epinephrine, norepinephrine, and dopamine. It increases a fight or flight response, and that increases the blood pressure, heart rate, respiratory rate, and in situations, blood glucose. So that's one of the assessment items that you want to do if you're suspecting sepsis on a patient. So putting it all together for suspected sepsis and UTIs, increased angiotensin could cause the electrolyte imbalances. The increased vasopressin, or remember, antidiuretic hormone, concentrates the urine and decreases the urine volume. Increased catecholamines increase your blood pressure, heart rate, respiratory rate, and can also increase your blood glucose levels. How about gut infections? Well, the gastrointestinal tract, when it has increased vasopressin, it constricts the arterioles. This increases the peripheral vascular resistance, which increases arterial blood pressure. The increased angiotensin can lead to metabolic acidosis, and that increased lactic acid we discussed, which is a hallmark for sepsis. This decreases the absorptions of nutrients in the gastrointestinal tract. The increased catecholamines causes the increased heart rate, respiratory rate, blood pressure, and blood glucose, and the increased gut mucosal bacterial infections can lead to some of the symptoms that you see patients complain of with nausea and vomiting, diarrhea, constipation, and cramping. Moving to skin infections, these can not only come from bacterial or fungal infections of the skin, but they can also come from surgical procedures, different types of medical devices that are in the skin, or pressure ulcers. Increase in vasopressin, again, constricts the arterioles. This actually causes tissue hypoxia. That tissue hypoxia, when you assess your patients, you'll see it demonstrated as pallor, cool skin, and especially cool and pallor in the extremities. Again, you can use your capillary refill assessment technique. The increase in angiotensin causes the vasoconstriction, which is a decreased blood flow to those tissues. So those tissues are really going to have a decreased ability to fight infection or pursue the healing process. An increase in catecholamines increases sweat gland production, because this is very similar to your fight or flight discussed earlier. For these patients, when you palpate their skin, you'll see that it may be sweaty, or they might have clammy palms or clammy feet. So the pathophysiology of sepsis is truly connected to your assessment findings. It all starts with an ischemic hypoxia that activates the sympathetic nerve-adrenomedullary system, which increases the four things that we reviewed: catecholamines, angiotensin, vasopressin, and endothelin, resulting in decreased urine output, increased creatinines, pallor, cool skin, peripheral pooling of blood or blood clots, increased lactic acid levels, electrolyte imbalances, hypotension or hypertension, tachycardia, thready weak pulse, decreased perfusion, which can also lead to decreased level of consciousness and potentially coma. Another assessment technique that's most often used in critical care is something called QSOFA. This consists of hypotension, systolic blood pressure of less than 100 millimeters of mercury, altered mental status, and tachypnea with a respiratory rate greater than 22 per minute. When the Q-SOFA scoring tool is used, a score of greater than or equal to 2 suggests a greater risk of a poor outcome for that patient. So one of the main things that you need to look out for, especially in our older adult populations, is an acute change in mental status. Now, further assessment techniques with your patient will be able to determine whether or not that acute change in mental status is delirium from sepsis, or whether or not you need to go down other routes, such as looking for a stroke or the sort of explanation for your altered mental status. Sepsis terms. SIRS stands for Systemic Inflammatory Response Syndrome. The SIRS criteria is a temperature greater than 38.3 or less than 36 degrees Celsius, heart rate greater than 90, respiration rate greater than 20, white blood cell count greater than 12,000 or less than 4,000, or greater than 10% bands. Systemic inflammatory response syndrome can progress to sepsis when you have 2 or more of the above SIRS criteria and a suspected or documented source of infection. Sepsis can progress into severe sepsis when you start to see signs of end organ damage. Q-SOFA scores can be used, and if you have a score greater than or equal to 2, you do have severe sepsis with that presence of either the suspected or the confirmed infection. Septic shock is determined when you have a lactate greater than or equal to 2, refractory hypotension, which isn't resulting from any fluid boluses, and that source of documented or suspected infection. End organ damage. When we look at the different types of organs, the signs of damage are shown here. In the brain, we have an acute status mental change, Glasgow Coma Scale of less than 15. Cardiovascular, the hypotension is typically greater than 40 millimeters of mercury below the baseline systolic blood pressure. Of course, systolic blood pressure baselines will be very different depending on your patient's body mass index, history of high blood pressure, or other comorbidities. A mean arterial pressure is a nice equalizer for most patients. If you start to see a mean arterial pressure of less than 65 millimeters of mercury, it's typically an indication that you have end organ damage in the heart, as well as decreased capillary refill. For the lungs, signs would be tachypnea of a respiratory rate greater than 20, difficulty breathing or maintaining normal SpO2 or end-tidal CO2. For the kidneys, you'll see a decreased urine output, and this could be calculated as less than 0.5 milliliters per kilogram per hour for the most recent 2 hours. Another sign for the kidney end organ damage would be a creatinine greater than 2.0 milligrams per deciliter. Lastly, our liver can show signs of organ damage with a bilirubin greater than 2 milligrams per deciliter, an INR greater than 1.5, or a PTT greater than 60 seconds, or a platelet count less than 100,000. So for initial resuscitation, the Surviving Sepsis campaign gives us the 1-hour bundle for initial resuscitation for sepsis and septic shock. The first thing that you're going to do is suspect the sepsis using those assessment techniques and the findings that we've just reviewed. You're going to draw labs, and that's going to be a lactate level, and you will measure that lactate level if it's elevated, meaning greater than 2 millimoles per liter. You're going to obtain blood cultures, preferably before administering antibiotics, and then culture urine, sputum, or other skin areas that you might be suspecting a worsening or new infection. The next thing that you're going to do is administer fluids. It's typically a rapid administration of a bolus, 500 milliliters in some areas, and then potentially continuing at 30 milliliters per kilogram of crystalloids for hypotension, or if your lab results in a lactate greater than 4 millimoles per liter. You'll also be administering broad spectrum antibiotics as prescribed by the prescriber, and then doing other treatments as ordered. That could be chest x-rays if you're suspecting something in the respiratory system. It could be EKGs for looking at something cardiovascular. It could be an EEG to rule out stroke versus some other acute process for your brain, and any other laboratory tests or diagnostic procedures that the provider will order. Now, if you have hypotension that is refractory to any of the fluid boluses, your patient will typically be transferred to an area that can use vasopressors during or after that fluid resuscitation, and your goal mean arterial pressure is going to be greater than or equal to 65 millimeters of mercury. For nursing management of sepsis, with stroke, we say time is brain. With heart attack, we say time is heart. And when we talk about sepsis, we say time is all of these, which time is life in sepsis. So assess the mental status of your patient, kidney and liver, looking for lab results in urine output and urine quality, tissue perfusion of capillary refill, your culture results, cardiac status, maintain frequency of vital signs, assess for new murmurs or new dysrhythmias. Respiratory status, how are your lung sounds, your respiratory rate, your SpO2, and an earlier indicator of hypoxia, which is end-tidal CO2. And always provide sepsis education to the patient and the family. This can be a very scary thing to talk about sepsis, but the earlier we catch it, the earlier we treat it, the better outcomes we'll have. And that's the way you want to make sure that everybody's on board with having clear outcomes and goals set forth with your sepsis care for your sepsis patients. Additional resources and reference are here, notably the Centers for Disease Control, Sepsis Alliance, Journal of the American Medical Association, the Society of Critical Care Medicine Surviving Sepsis campaign, and Nomadic-Nurse74.com, which has additional videos reviewing evidence-based practices, relaxation techniques for nurses, and other things that might really make your day. Thank you so much for your participation, and email me if you have any questions.